Boston, we're notoriously provincial and parochial, but Marathon Day, it's a day when Boston is most welcoming to the outside world.
I didn't hear it. I didn't feel it.
A lot of people there were still smoking, their clothes were still on fire.
No, this didn't happen. This can't happen.
He put his hand on the stretcher, and I just remember him saying, "We'll figure this out, and I love you."
It was a living hell to have two boys with those injuries at the same time. And even though they're older, they're still your kids.
They decided that in the name of their faith, it's okay to be blowing up the Boston Marathon. And that's what makes them monsters.
911, what's the emergency?
I have a boat in my yard. There's blood all over the inside.
We have a person in the boat alive.
Everybody go! Everybody go!
Everybody has post-traumatic stress. You almost feel less of you, but them watching me accomplish things that I hadn't done before kind of heals everybody.
Yes! Woo! So much was taken from us, but not my sense of humor. You're the only one with the right leg, buddy, so it looks like it's just you today.
I'm the only one with a leg.
I carry Jess's spirit with me. I carry the spirit of our families and friends, our city, and I carry the spirit of the guardian angels who were killed.
Okay, well, I don't know about you guys, but just watching that for me was pretty traumatic. We're privileged today to have Jessica Kensky and Patrick Downs with us, who are featured in that trailer to the HBO series, or HBO documentary. And so I found the two of you sort of in preparation for this meeting, 6 or 7 months ago.
I think the proper word is stalked. He stalked us. He told us last night he found our addresses for the last 7 years in some database. So I think stalking is the more appropriate word.
So this is how this interview is going to go. Okay, you're laying out the ground rules right up front. All right, very good. So anyway, I sent them a letter and I asked them, knowing where the meeting was going to be and what we did as a society, to be with us here today. And so what we're going to do is sort of go through their experience and what's happened to them and their struggles and issues, and hopefully we can all learn something. And they have things, I think, to teach us as well. Mostly today is going to be you teaching us. So if we can start by just tell us about your lives and where you're from, and what were things like prior to Patriots Day?
Good morning, everyone. It's nice to be here. We were happy to be stalked, to be in a group with all of you today. We were newlyweds. We had been married 6 or 7 months before the bombing. We were living in Harvard Square, which is just down the street from my childhood home in Cambridge, Massachusetts, right across the river from here. And we were just kind of figuring out life. Jess was an oncology nurse at Mass General. I was completing my doctorate in clinical psychology. And we had both run the race in 2005. We didn't know each other. I was a senior at Boston College, and Jess ran with a friend. I had recently found out that I had been matched for an internship at UC San Francisco, so we were going to move to San Francisco, and Jess is from Sacramento. So I figured we'd never be back in Boston again, certainly not back in time to be here for Patriots Day, which is the day that the marathon is run on every year. And for me, it's always been a holiday. From the time that I was a little kid, we would always be aware of the marathon. In fact, we would listen to the marathon on the radio. And there are few things more boring than listening to a marathon on radio, but we did it.
Tour de France might be.
Yeah, the Tour de France, yeah, exactly. But we did it because it was such a cherished day in our city. Jess and I decided, because we were about to move, that we were going to go down to the marathon that day. We left our apartment, walked to Harvard Square, took the T, which is our subway system, to Park Street, which is where the State House is, and then just walked through the Boston Common, through the public gardens where I had proposed to Jess, went down to Boylston Street and just kind of nestled into the crowd. We were taking pictures of people who had finished their races with their families and just took in the spirit of the day, which is if you've ever been here for it, is incredibly infectious. And then all of a sudden, things just changed very rapidly, without warning, without any awareness that anything dangerous was about to occur. That's when my memory cut out, I think, from the blast wave and from hitting the sidewalk potentially. I guess I was conscious, but not really processing what was happening or storing any memory.
Were you able to see each other afterwards? I mean, you both went to separate hospitals, but were you able to see each other before you were taken away? I mean, did you know where she was and vice versa?
Yeah, so I was picked up first. There was a lot of first aid available at the finish line, but it was really set up for like dehydrated runners and things, so no one was prepared for what they were faced with. But I was picked up on a stretcher and taken to the tent at the finish line, and I assumed Patrick was going to be following behind me, and he was never brought into that tent, and that's for me when the panic set in. Patrick lost consciousness. His
so you didn't know he was okay?
No, and in fact his injuries were much more graphic, I guess, than mine. I was wearing these boots, and all of my injuries were all along the back of me. And so I think it was a good thing, couldn't see them. I knew I couldn't stand. I thought maybe my legs were broken, but I had no idea what I was facing. But Patrick's foot was off. So it was I was very concerned about him and unable to help him. So we were eventually taken to separate hospitals. I will say that every single person that made it to a hospital survived, which is really quite remarkable when you actually look at the numbers of people injured. There were hundreds of us, and there's 17 of us that are all lower extremity amputees. And for the most part, we were around the same age and stage of life. There was one young woman, she was only in second grade, Jane Richard, who lost her brother as well, and then one older gentleman who lost a leg. But for the most part, we were all in our 20s, 30s. But Patrick and I weren't reunited. It took 2 weeks before I stabilized enough for my care team to transport me. I was taken to Boston Medical Center, and Patrick was at Beth Israel. And obviously, I mean, so much went into those equations of who went where to not overload any one hospital. It was really phenomenal. And the fact that it was a holiday in Boston meant ORs weren't running at the same capacity.
A blessing.
Yeah, blessing. It also happened around change of shift for a lot of emergency rooms, so they were able to have their earlier staff as well as the later staff there, so they were like double staffed. There was a lot of very fortunate, the roads being shut down, we got to the hospital really quickly, there being so many hospitals. A lot of military participate in the Boston Marathon, and actually a lot of our first responders had military experience, and frankly, I'm a nurse, and had I not been hurt, I don't even know how helpful I could have been in that situation. You really needed someone who was prepared to make tourniquets out of whatever was laying around, and give first aid in a way that I wasn't trained to do. So for a lot of reasons, we're able to be with you today.
So these devices were sort of packed with bearings and all sorts of things. So it really was almost essentially a military event. And you'll see by the x-rays, it's a confirmation of the fact that this was essentially almost like an IED explosion.
Yes.
In many ways.
We found out after the fact that the reason why Jess had sustained so many burns and injuries to her backside was because the bomb was behind us and slightly to the left, only about a foot and a half or so. So we were very close to the explosion. And Jess was standing behind me with her hands on my shoulders, trying to use me to get a little height to see the runners. And unfortunately, that meant she took the brunt of the explosion.
So we were going to start with you, Jess, and run through some of your injuries. So they've been kind enough to send me all of their images and medical records, and I had a chance to sort of go through them and sort of distill them down. So this was the right leg, and
we forgot to introduce Rescue.
Yeah, I forgot to introduce Rescue.
Yeah.
Rescue will actually is the service dog who will be highlighted later in the presentation. So he's waiting his turn, staying rested and cool up here on stage. Okay, so this was the the right leg and the left leg, and here you can see the, I guess you'd call it, bearing, shrapnel material. The x-rays, I don't think in any way, shape, or form do the justice to the soft tissue injuries. Jessica's injuries on the left side were such that she had an immediate below-knee amputation. But the injuries to the right leg, and we'll show you pictures, were severe enough that, I guess, was there discussion about it, or was it just, we're going to salvage this right leg, or?
Obviously my memories are very foggy during that time, and I'm sure a lot of you, if you've dealt with trauma patients, there is this very natural instinct to save. People want to keep any part of themselves that they can. That seems like that's your best bet. So when I woke up and was told I lost my left leg below the knee, I went to the OR. We pretty much went to the OR every other day. It would be a washout, half a day off, and then they'd go back in to try to see what they could do, and then another washout, and it would alternate like that. So every time I went to the OR, I knew that potentially I could lose my right leg. And every time I came out with it and it was still there, or what I thought was a leg was still there, to me that was success. So it wasn't really, we didn't have a real discussion, at least not that I recall. It was kind of like, you might lose it, but every time I came out with it, it was kind of like this triumphant moment of, it's still there, this is great, I'm gonna get to keep it. But no discussion about what limb salvage means, what that can look like, what that journey is like, how different that is from a nice clean amputation. Where some of our cohort had military surgeons, well, they had military experience and they were now at civilian hospitals, or maybe had more experience in limb salvage. So some of our friends, we're now friends with all the other amputees in particular, did have more conversations and actually were introduced to people who had gone through limb salvage to talk about what that could be like. And there were conversations about, you'll never run again, you'll never wear a women's shoe again, like things like that. I don't recall any of that with my situation.
So can you comment on your pain management during that period and your recollection of it?
So my right leg, let's see, well, pain management, the early days, it was really, I was covered in burns, horrible burns, and to my vagina, rectum, whole backside, and I was in an ICU bed, so trying to prevent pressure ulcers and being turned. The burns is what I remember as the most painful thing in those early weeks. And for that, I was really just on IV narcotics. And then the phantom pain didn't set in. It took about 6 weeks, I think. We were both out of the hospital and in a rehab hospital, and that's when the phantom pain really hit. And that was startling. It was really scary. I think a lot of people don't understand phantom pain. I thought it was just the feeling that your leg was there. I didn't know it was gonna hurt, but Patrick and I both would get these electrical shocks. And we've now learned, being younger and healthier, and the more traumatic the injury, actually the worse the phantom pain is. And it's not well understood. And for those reasons, I don't think we have a lot of great ways to treat it. So the pain management was not great for a while. I will say
So nothing regional?
No, I think for me it was the burns. I don't know that they had any good, clean place to put a catheter in. Much later, you'll hear I ended up at Walter Reed. I was a patient there for 3 years. I had great pain control and was able to do peripheral nerve blocks, which were so helpful, and to avoid narcotics was just made such a big difference in my post-op recovery. But early on, I think they were very limited as to what the options were.
So the soft tissue injury was significant to the back of the leg, the heel. You lost essentially the Achilles insertion and the calcaneus.
Yeah, my whole Achilles tendon was gone. My calf was kind of balled up. My heel pad, for the most part, was gone. What was left of my calcaneus was kind of like a sharp bone that would poke through. So I think it was, so when you're a patient laying in bed and looking at that, I'm not looking, what I see looks pretty good, actually. And I think it was very hard for people to move me towards amputation when so much looked good. But I was missing so many vital parts that you just can't recreate. Like, I have a whole new appreciation for a heel pad. And I ended up with an ATL.
Yeah, can you stay with that? Stay with the PowerPoint.
So before I left that first hospitalization, I had a free flap surgery, which by all, everyone was like, it was so beautiful. It was so great. There was such good blood flow, So I had this big piece of my thigh kind of glommed onto the back there, covered it nicely, but just function-wise was, I'm not gonna know for a long time, right? Because that's the thing with limb salvage. It takes so long. All of my kind of cohort was up and walking and trying to get back to life, and I'm still doing 5-minute like dingle time, right? I don't think I took my first steps really till September, and I was hurt in April. So it was a very long process, but surgically this looks good, right?
Plastic surgeons are very happy. They're like thrilled. They're high-fiving everybody, right? Because their flap looks fantastic.
Exactly.
Right. So we're going to move on, Patrick, to your injuries now, okay? And so this is Patrick's and again, you can see the shrapnel in the wound and quite high. And again, that resulted in an immediate amputation as well.
Correct. So again, I don't recall anything that happened only from Jess's memory of it, but we found pictures after the fact, and my leg was gone. I mean, it was hanging on by a thread in a wheelchair as they wheeled me to the medical tent, but it was done. So I woke up, and my parents told me that my leg had been amputated. But the complication was because of all the debris from the street and what was packed in the bomb led to a pretty significant infection in my leg. And then we got into a conversation about how long my limb was below knee, whether that was viable to be an active, young, healthy person, and how to eradicate this infection without having to take too much soft tissue to keep me moving. So I had an amazing team at Beth Israel Deaconess. I happened to be born there in 1983, so I always feel now that I've been reborn there. And I love these people. They were incredibly devoted to my care. They were so determined to communicate with me, to collaborate with me. One of my doctors, a trauma doc, came in on a Sunday afternoon and he said, I got it. And he had been at home all weekend thinking about me and had come up with a new treatment plan to help with the infection, that they would go in, they'd wash me out, then they'd send me to Mass Eye and Ear Infirmary where there was a hyperbaric chamber. And he thought that could really help to stimulate some healthy growth back in healthy tissue. And sure enough, after doing that for a week, my body really rebounded, and I saw a significant advantage from that.
So, but then you had almost a day or two apart, when you had your ALT flap, you had your gastroc rotational flap and skin grafting.
This one, yes. So I had initially I was closed with a skin graft. They knew that wasn't going to be sufficient for me because it just wasn't enough padding. But they determined that my body had already been through so much, I had already knocked off this infection. It wasn't worth giving me a flap that could potentially not survive. So we waited 6 months to do that. So, well, a little more than that. I was hurt in April, we did it in December. I also developed heterotopic ossification during that time. So that began protruding through my skin graft. And the tissue is terrible. I would put it in a socket, I'd start walking, I'd feel great, and then I would take this socket off and realize that I was bleeding.
Yeah, so this is Patrick, what he looked like before the free flap surgery, and he was like, let me get this straight, doc. I lost my leg, and now I have a vagina, because they told him he has a terrible invagination.
It really seemed cool.
Double whammy, huh?
Yeah, and no one explained what it meant exactly.
It's like, but you can see, I mean, the skin graft, it was really like fixed. It didn't move at all. He didn't have good sensation. He's got this big invagination. And then we both, and a lot of us from the bombing, developed HO, which I swear, it just comes in the most problematic area, usually at the most problematic time. But I do think that waiting for that, I think we were emotionally and physically just so worn down, and it actually gave his body time to develop the HO. So when they went in for the parascapular free flap, I think they were able to kind of kill two birds with one stone at that time. But when he was up and walking on this, I mean, it was very disheartening and really upsetting. And you're thinking, I'm supposed to live with this thing? And he would walk from here to the back of the room, take his prosthetic off, and it'd be covered in blood. And for him, that parascapular free flap was just a big game changer.
And that, by the way, was after consultation with doctors from the military.
Why don't you jump in with how that connection got made and all the sort of the details of that.
Jess's father is a radiologist and an incredibly determined man, particularly when his daughter's involved. And so he knew that we had received great medical care, but there was something missing from our recovery process. And so he went on this exhaustive search of our country to figure out what kind of resources we had, and eventually realized that the military is who has done this the most and really has this expertise. So he was able to recruit doctors both from Brooke Army Medical Center and from Walter Reed to come to Boston Medical, and invite all the amputees from the bombing and give them the opportunity to have a consultation with these military docs along with their civilian doctors. So in my case, my plastic surgeon from Beth Israel joined the meeting, and they shared their experience doing these parascapular free flaps. And he was, Dr. Kim is his name, he's the most incredible man and incredibly humble too. And so he loved the idea of collaborating with them. He set his ego aside. He said, I don't really know how to do this. I'd love to learn from these people. That wasn't always the case. We ran up against so many egos, it was exhausting.
A topic for later conversation.
But actually really does influence medical care. We found so many surgeons who thought that they were God and were unwilling to consult with other doctors or to really effectively communicate with us. And so we didn't work with them because they gave us no confidence in their ability to do good by us. But this consultation from these military surgeons really was a turning point in my care, and also a sign to us eventually that we needed to access that care for more round-the-clock rehabilitation for Jess.
But they had to be formally asked. There's sort of you were describing, and maybe Joe or whoever's here from the military can comment about the need to be invited into the care of a patient, correct?
Our understanding is that they can't solicit civilians, so they needed to be invited. So by the civilian doctors inviting them in, that kind of opened the door. And as soon as the bombing happened, now that we've spent a lot of time at Walter Reed, I've had countless surgeries there, and I think when it first happened, they wanted to come and felt like an obligation to come, and there wasn't something set up to do that. And not to get too off track, but now Patrick and I have worked on a bill with Elizabeth Warren that, God forbid, this happens again and there's more military-style injuries for civilians, that civilians can access military medical centers with their own insurance, and if there's beds available, and there's a lot of caveats, but the point is that a lot of men and women had suffered for them to develop all these policies and procedures and protocols, and they've learned a lot, and why not share that with other people, right? I mean, I think that makes us all better at our jobs when we do that. But here you can see Patrick had just the best possible outcome. And his residual limb, by the way, is not long. I mean, there was a lot of surgeons who didn't think he was gonna be a successful below-knee amputee. And he has been, he ran the Boston Marathon. He wears his leg all day, every day. A few amputee hiccups here and there, but for the most part, he's a very high-functioning single below-knee amputee. And I don't know that would have been the same. An above-knee amputee is a much different beast in a lot of ways. And to take a young, otherwise healthy man and take that knee when you didn't have to, I'm just so grateful that this was his outcome.
As an aside, I believe, and maybe you don't remember this, but when I was going through your records, it looked like you were part of the bioburden study from Metric, because in your op note for your free flap, they talked about taking multiple pieces of tissue for an infection study. And that was right during the time period of bioburden, and I suspect you were part of you probably don't remember signing up for that, did you? But you signed up for some study they were taking tissue for.
Informed consent when you're under pain meds isn't all that effective.
It was in your op note, so anyway. Okay, so at this point, you've got a free flap on your leg,
yes.
And you've got this, and now we're about 6 months out. So tell us about the journey and the timing of getting to Walter Reed.
I mean, I would describe that time as Patrick really taking off, as well as kind of these other peers. I told you there's 17 of us. And it became very clear to me that I was not where I wanted to be and where others were, and I just couldn't figure out why. You know, when someone said, "We saved your leg," I thought it was what I considered a leg. And it was pain that was really holding me back. And pain is subjective and you can't measure it. And I really questioned, am I trying hard enough? Why can't I get better? Do I not want to be better in some weird way? I just started, I was really getting around poorly.
Jess, can I ask you to be more specific? Is when you say pain, was it your residual limb or was it your salvage limb?
It was my salvage limb. It was in my heel and my ankle. And I could get about 15 minutes of standing or walking, and then it didn't matter where I was. I had to sit. And at this point also, during Patrick's free flap stuff, my father had researched the IDEO brace, and it was available for the first time to civilians only in Tacoma, Washington. So during all this, we were traveling to Tacoma, Washington, and I now have a military-grade IDEO brace.
Can you hold right there just for a second? Because I think what we have on the video is your first walking on the parallel bars.
Yeah.
So this is September now, about
These are my first steps.
6 months. No, not quite. A little, 6 months.
6 months,
yeah.
So this is after just, the dangling that went on till you could have your leg dependent for an hour. 10% weight bearing all the way up to 100% weight bearing.
What kind of shoe were you getting into?
So that was this is a very extra wide women's running shoe to accommodate that massive heel flap. The shoes got bigger in the IDEO brace because that's even bigger and bulkier. At that point, I couldn't wear a women's shoe of any kind, only a men's extra wide shoe.
Okay, so you got to Walter Reed, you got fitted for the IDEO brace at Tacoma.
Yep.
And are you still then at Walter Reed trialing the IDEO or working with the IDEO?
So
where are you now?
Yeah, so when I showed up to, basically before I got to Walter Reed, the IDEO brace could get me walking on uneven surfaces, walking faster, and maybe up to 20 minutes, let's say, of walking or standing. So there were improvements, and I think we have a video. This is what I submitted to be considered for the IDEO brace. So, you can just see how I'm just over-rotating on that ankle. It's flop. I have no stability on that side. By far, my good side is my amputated side.
So you sent this to sort of justify your...
It was part of the evaluation process. Yeah, they don't want you to fly all the way out there if they don't think you're going to be a potential candidate. So that's what I submitted. And then I think we have a video of me in the IDEO brace. And I think it's good to look at because after seeing this, now look at me.
Now this is December, 3 months later.
Yep, this is in Tacoma trying that IDEO brace out. This is the test IDEO brace. I'm more stabilized, I'm walking faster.
There's a little bit of a smile.
There's a little bit of a smile. I think the point being that it's so hard to figure out what success is, and it's a combination of what it's defined by the patient and their care team and their family and their goals, and that you can have these times that look like you've achieved success. But for me, I was still in pain. For me, the IDEO brace, for some people, they use the IDEO brace for higher level activities. So they're able to, walk to the bathroom and in their house, but to run or do higher level things, they need the IDEO brace. I needed the IDEO brace for everything.
So just to be specific again, was it again, function or pain or both or?
Pain.
So you
Pain was
still
my
had the
limiting,
pain.
still have the pain. The nature of it changes. It takes a little bit longer for me to hit the same level of pain. But then, before I got to Walter Reed, I started actually shearing off bone in my ankle because my ankle has all this hardware in it. And it's almost like the IDEO allowed me to achieve more, do more, but then I was hurting myself more.
So this is about a month later now. This is your second IDEO trial.
Yes, which is like...
Yeah, wow, look at you go.
And the gentleman who makes the brace is a prosthetist, so he just is very uniquely positioned. And everyone was so excited. Everybody was. And
were you excited?
No.
Okay. That's probably an important point.
I remember her that night. We went back to the rental home we had in Tacoma, and she said, I'm not going to say this to anyone else, but I think I need to amputate this leg. And it was such a shock to me because I had just seen her reach her best heights so far since our injuries, and yet she just knew that it wasn't going to be enough.
So when did you feel safe to say that to someone? Or did someone say it to you, or how did that conversation go?
No, I mean, it's funny. In the beginning, it was always the threat. You might get this amputated, you might get this amputated. Then we hit this stage where no one was talking about it, and I was thinking it. And it took me a while to start to say it, first out loud to my husband, and then to some of my care team. And then no one wanted to hear it. It was really something they weren't willing to go there. We had tried, we'd done so much. I was thinking about this for today. I had this really old car in nursing school, and it kept breaking down. And you buy a new part, and you pour more money into it. So then when it broke down again, it was even harder to let go of that car because you just poured all this time and effort and money, and you can't buy a new car, for the amount that you have to pay to fix it. So you just get in like deeper and deeper and deeper with this piece of shit car. And that's where I feel like I was with my limb. And
psychological trap.
Absolutely, but most importantly, I think that for better or for worse, and I don't fault them, a lot of the doctors that I was working with were right there along with me. I think no one wanted to see, this young, healthy woman, newly married, become a double amputee. This was something that happened that a lot of people felt like never should have happened. You can just
a
go
lot
too.
Of psychology and emotions at play.
Yes, and I felt the pressure to feel excited in all these moments. Like I wanna be a good patient. This guy just invented this brace. Like I wanted it to be successful. I wanted that to work. So I think that's for me the big takeaway here is how much of the psychology is at play with all of these decisions.
Well, you're a good patient. I mean, you're the kind of, both of you are the kind of patients, like you're all for it. You're in there, you do everything you say, incredibly compliant. You're like dream patients.
We also had more resources than anyone else that we know, save for our friends in the military. We had a father who was a physician. We were in the Mecca of medicine in Boston. We were hurt in this high-profile way, so people wanted to jump in and help. We had financial resources that people had given.
So we're going to talk about that in a little bit.
Like we had so many advantages that met so many people who we've met who are amputees or limb salvage do not have. Yeah. So we have no clue how you navigate that with anything less than what we had.
And so this is January, so by August of this year, through lots of advocating and letters and phone calls, I show up at Walter Reed with a civilian designee status to be a patient, and I'm evaluated by their care team.
Wait, what? This is August, so 6 months.
So.
What year are we talking here now?
August of 14.
Yep.
Oh, so this is a year and a half after
the bomb.
Yes, that I show up at Walter Reed. And this is how I look. This is how I'm getting around. But again, in these short increments, lots of pain. Famously, I'd start a grocery trip, and when I hit that threshold, abandon the cart, I was gone. I was out of there. I mean, it completely changed my personality because people always freaking stand at parties, which is like, so anything social, I can't even listen to what someone's saying because I'm just looking for the nearest place to sit. Very, horrible depression, anxiety, it just the whole bit. So, but contrast that to, look at me right there. I'm climbing up this like uneven hill. A lot of people with 2 native limbs can't do this.
So take us sort of in a time frame and psychologically to the goodbye to the leg party.
Walter Reed, even when I got there, I did continue with limb salvage. The difference there was they gave me a very real timeline, at which point if I was defining success, and if it wasn't successful to me, they were gonna be on board with me for an amputation. But they did talk me into an ankle fusion, and then I did this like something to try to deaden the nerves. They also, by the way, did a lot of work on my left limb because I was too long, believe it or not. I had no good padding. I had HO, so they did some cleanup on that side as well. So the goodbye to the leg, I had an amazing PT and OT, and I did, they sent me home for the holidays, so.
Which holidays are we talking
So
about?
Christmas of 14, and I had a chart to every day, it said, the cover said, chart yourself a merry little Christmas. And every day I wrote down the activities that I did, my pain level, the time, and then most importantly, the activities I avoided. And after charting at home for a couple days, it was just so clear that this leg was holding me back and I didn't want to live my life in 15-minute increments. And I had to amputate my leg. And I think for a lot of patients, that exercise could have been upsetting or painful or not helpful, but it's my care team learning about me and knowing that I needed some as much evidence as I could that this was my best decision. And we all know no one's guaranteed a good outcome. I was not guaranteed to be an active double amputee. There's still a lot of potential pitfalls and roadblocks. But at that point, I went back to Walter Reed after the holidays with my occupational therapist. We did some kindergarten art where we were painting the bottom of my right foot and doing an art project and joking about how it was gonna be worth so much the next day because my leg was being amputated. And again.
Like when an artist dies, the art goes up, goes through the roof.
But again, this was just part of, that left leg, I didn't know I was losing. It was a very different experience. It's very bizarre to schedule an amputation. And then for me, it was really weird to have, I can't believe I have no feet and no toes. It's very weird to not even have one to demonstrate, so to have this goodbye was, I don't know what you do the day before your second amputation. This was just how we spent it.
She went and got a pedicure. We went down to the eastern shore of Maryland and she put her toes in the sand for the last time. We really thought
you
about
got
this.
one as well.
I did.
It was his first and my last.
Yes. Also my last. My first and my last.
So I should have had pictures of that.
I know, right? We told the poor girl, we're like, no pressure. It's just my last pedicure on earth.
So she's crying her eyes out while she's giving the pedicure.
So when was the amputation? Second?
So that was January of 15.
January of 15, okay. So how did that go? Tell us about how it went and your recovery from the second amputation.
My recovery went smoothly. I had great pain control. It was like, I'm an old hat at this, I know the whole game. I know about shaping my limb. I know about wrapping it. I've got this, right? And then I had so many setbacks, horrible infections, weird infections, by the way, ones that we had to consult the NIH for, which was great because we were across the street. I had these bursa, these really problematic bursa that would get orange sized, and then they would swell and go down and swell and go down, so you can't get a good socket fit. And a couple bad falls, actually. That's when I would not recommend one prosthetic and crutches. I no longer do that because I've had some really bad falls that also led to setbacks. I broke my bone bridge. My myodesis tore.
You broke your bone bridge?
Bridge, my urdle.
Oh, you had an urdle?
Yeah.
Ah.
Broke it.
Were you part of the metric urdle study as well?
I probably signed on for that too. I'm just, signing my name. So it wasn't, it took, gosh.
Over 2 years.
2 years.
Until she, because there were so many falls, bursts, infections, setbacks, surgeries that would follow those, recovery periods, another one, recovery periods, surgeries, that it extended for 2+ years to get her to.
Where were you living during this period?
At Walter Reed. We were there for 3 years, and we lived on base in the same dorm complex as the service members.
Okay. So when did you finally leave Walter Reed?
In June of 17.
And what was your status at that point? How were both of you doing it?
Well, I was officially charted as a community ambulator, which was my goal during all of this. So I left wearing my legs pretty much all day, every day, routinely hitting 10,000 steps. Patrick had run a marathon. I learned how to drive with hand controls. I had gone back to school to become a nurse practitioner. We came home very fit, very strong, and excited. Yeah.
So what did you come home to? What kind of living situation? Tell us a little bit about how that worked out.
We have a condo in Cambridge that we were able to purchase just before we left for Walter Reed. It's not ideal. It's a 2-floor city condo, but there was incredible generosity from the city of Boston, Massachusetts, and architects and people of that skill set donated their time to make people's homes accessible, widen doorways, change layouts. They installed an elevator in our condo that someone donated, which is otherwise a $25,000, $50,000 piece of equipment. So again, to the resources that we had access to. So we still are there. It works well for the time being. We imagine that someday we'll need a 1-floor unit somewhere just for ease, but it has worked so far because it allows Jess to quickly get to Mass General for her nursing shifts. There's a park next door for rescue, which he loves, and we're not far from my parents, who are just on the other side of Cambridge.
So 2 questions. So tell us about your employment situation like right now. What are you doing?
So Mass General donated thousands of hours of earned time to me because Patrick was a student and I was carrying the insurance as well as paying, the only one with a household income. So
she reminds me of that fairly often.
Whenever I can.
I'm the second one listed on the car ownership, the condo ownership, the dog ownership.
Are you feeling vulnerable here?
No, I'm just laying it out there.
But they donated so many hours that those years that we were trying to get better and traveling and at Walter Reed and everything, we got my salary and health insurance. Then when we moved back, my manager, I was an oncology nurse working 12-hour shifts when we were hurt. She created a position for me on the unit. So I was with my colleagues, but I was working on patient education materials. And while I didn't love that job, it was a big deal for me to get up, get dressed for work, commute to work, be on time, be accountable. It was kind of like, it was reminiscent of being a kid again. And even just learning how to talk to people at work. I had been a full-time patient for 5 years. It really is a hard role to transition out of. And I think it's important to point out just how incredible our employer has been for both of us. So I started there. As my mobility and strength continued and my, I think not being so exhausted from talking and interacting with people, I'm now back at being a bedside nurse in an outpatient oncology clinic, also at Mass General. The idea being that if you're well enough to be home, those patients should be more mobile. It doesn't always work out like that, but that was the theory, that I wasn't gonna need to be lifting them. And my shifts are a little bit more flexible, and then I'm still in school part-time. And then Mass General also gave this guy a job.
Yeah, tell us about what's going on for you.
I work at a psychiatry clinic of Mass General called Home Base, and it's for military veterans, active duty service members, and their families. And so I do a lot of individual therapy with men and women who have served or are actively serving, from combat trauma to anxiety and depression that all humans experience, and that entire gamut. And I think that opportunity came out of all the people we knew at Mass General and their kindness and their commitment to see us get back to the lives that we were living before. Again, that does not happen. We have so many friends whose employers said, we can hold your job for 3 months, or maybe 6 months, or maybe we can have you come back in some kind of part-time fashion, but it didn't really work out, and they weren't willing to be creative to find them a new position, and then they were unemployed. And so we are incredibly grateful for the opportunities that we've had and know how much of a difference that makes, not only in terms of finances and being engaged back in your community, but having some sense of purpose again, that we don't just see each other, our identities aren't just formed around being patients. We are now a nurse and a psychologist again.
Yeah, back to some identities other than being patients.
Right.
Can you tell us about One Fund?
Yes, the One Fund was a financial fund raised created within hours after the bombing. The city of Boston and many of the companies around Boston knew that there was going to be a need. And so almost immediately, John Hancock donated $1 million and kick-started the fund. And that snowballed into a fund that over the course of months raised $80 million. And that is an enormous sum of money just on the face of it, but also relative to many other tragedies we've seen around our country and funds that have been started for the survivors of those attacks. And it makes you wonder about how we support people who go through these tragic attacks. Whose responsibility is it? Is it private citizens? Is it our government? Is it a combination of the two? Because there's significant cost that comes with all this. And frankly, there's a lot of fatigue. Once we see these attacks over and over again, it doesn't stay on the news as long, so people's investment in them isn't as long. And so the ones who are directly impacted are kind of left to figure things out. That has never been the case in Boston. To this day, people have given us financial gifts, gifts in kind, invitations to things, connections for employment. It really makes you wonder what role the community plays in supporting people after trauma.
And I think, Patrick and I are well aware too, we could have been in a car accident and had very similar injuries and would not have had this just amazing swell of support. And so how people are dealing with more anonymous trauma and tragedy with none of these resources. We always say we cannot imagine doing it with less.
We were seen as demigods around the city. We've thrown out the first pitch at Fenway 3 times. We've been in parades. We've been invited to ribbon cuttings and different events. I mean, people really wrap themselves around us. And, you have to check your ego amongst all those great activities, but it's such an incredibly warm welcome, and you really feel like you're a part of something special. And a lot of people really feel anonymous in the wake of their injuries and traumas when they're not done in such a public way.
I think, can we pan down to the sleeping dog and maybe introduce Rescue? And why don't you tell us a little bit about, he's waking up, there's Rescue. Why don't you tell us a little bit about this guy?
So tired. So this is Rescue. I got him 6 months after we were injured. I was visited in the hospital by a service dog because my nurses just found out I love dogs and made arrangements. And, he's really waking up. Can you grab his leash? But so Rescue is a trained service dog for someone with a permanent physical disability. And as soon as I kind of shifted my thinking into realizing, I went into the hospital very healthy and able-bodied, and I had to shift my thinking that that's not who I am anymore, and whatever tools are at my disposal to live a fuller life I wanted to have. And he is by far the best and the cutest medical device we got. So he can turn off lights and open doors and bring me my cell phone and bark on command if I needed help. Nuzzle Dr. Reid over here. But also he was a huge part of our mental and emotional recovery. I didn't sleep through the night until we got Rescue. he also needed to be taken care of, right? So in the Boston winter, I had to figure out a way to get outside and exercise him and throw the ball and play with him. So during the deepest, darkest part of our kind of depression and immobility, you had to take care of this beautiful animal. And I don't think I, at the time, could appreciate what a positive impact he was gonna have on not just me, but Patrick. And really our whole family. I mean, when people came into our apartment in those early days, no one knew what to say, what to talk about, where to look, but like, what a great distraction. So much so that you wanna show them our work? Yeah. Our side hustle?
Jessica and Patrick wrote a book about rescue and Jessica and had it illustrated. And just a quick, I'll make the commercial. After this, they're going to be outside at a table and they will sign, you can purchase and have your book signed by the dog and both of them. So it's a, wonderful Christmas gift.
We call it a potograph.
So, but it documents the whole story of, what happened, and it's really quite touching.
A lot of it came out of our interactions with kids when we go out in public. So we go out grocery shopping in the middle of the summer, and kids would see 3 prosthetic legs, a dog with a cape on where they don't usually see a dog, and their eyes are launching out of their heads. What the hell is happening here? And they're grabbing their parents trying to get some explanation. And what we found is that they were initially sort of fearful. They saw our injuries and imagined that we were in pain. But once we invited them to come over and check out our prosthetics and pet rescue, they started smiling, and they became fascinated by it and had all kinds of questions about how our prosthetics work and that we were like robots and that rescue could do all these cool things. And then they were just like really curious, and we were just enchanted by those experiences over and over again, that we felt like it was worthwhile to put it into a book form. And we've found it to be really helpful when we inevitably get calls that someone's child has recently had an amputation and they're really upset, so we go in and visit them, bring rescue in the book, and they can really see themselves in the book and imagine what life could still be like. And we've given it to friends who are adults who have had amputations and have kids and are trying to explain to their children what has happened and how life might continue after that.
Yeah, and it is a children's picture book. It doesn't talk about the bombing. It's not graphic. But we've done so many school visits with it to talk about people that look differently, get around differently, start to think about people with disabilities, people in your community. We've sent it to all the prosthetic offices that we've interfaced with, and we think they need to be in your orthopedic offices.
Okay, so you're addressing a group of limb reconstruction surgeons. And what's your best advice to us when we're taking care of folks like you?
Communication and collaboration. The people on our medical team, whether they were psychology or surgeons, if they communicated with us, if they were a part of developing a treatment plan with us, we had far better outcomes. I'm sure that you all are incredibly talented technicians, have great skill sets in the crafts that you have studied for so long and have worked so hard for. But ultimately, this comes down to a human element. This is a massive life decision that people are really grappling with, and it has so many implications for their life and for the lives of the people in their circle. And really effective communication goes a long way to help people understand what to expect, how to manage obstacles as they inevitably arise, and how to really join together on some kind of treatment plan that makes sense. Develop a timeline that seems reasonable, that people can measure some objective success or lack thereof. It's an incredibly delicate situation, and I think the human element is so important in it.
Yeah, I definitely second everything Patrick said, and I think, like it or not, you have to deal with your patient's mental health. I think their mental health has such a big impact on how how well they're gonna listen to you, how well they're gonna attend physical therapy, how they're gonna view what you did, the success or not the success of it, and whether, I realize you're not necessarily in the position to be their mental health provider, but helping to connect them to someone. Maybe they're a great candidate for a service dog. I mean, these things are gonna impact your care, like it or not. So I think recognizing maybe you just need to get someone through this really terrible time, through this recovery, and then they might have a great outcome. But if you can't get them through that time, it's kind of all for naught. And then I think a timeline is so important. For the patient, it can seem just like such an endless struggle. And to have, at least we're gonna reevaluate here. We're gonna have a talk here. They're counting down to something. They're looking forward to something and some movement and some decision. And then I think as clear as you can to be the communication of success. What is success to you and what is it to them? Because if that doesn't line up, again, it doesn't really matter what you're doing in the OR, right? Don't be scared to reach out to many other resources, whether that be social workers, mental health providers, other colleagues for ideas or brainstorming. And then the other thing is how important mentors can be. I think if you have an idea of some of your former patients who could be a good mentor for someone, not to hesitate to connect people. That was incredibly powerful for me in making my decision. I mean, we obviously just scraped the surface here with, we tried to give you the highlights, but for me, meeting double active amputees living really full lives was so important for me as I was making this decision. And no one can replace that knowledge of a mentor, so helping them with that as well.
So sort of a final question for you before we open it up for some questions from the audience. So, worst fears, best hopes going forward?
For me, my worst fears were in those initial days of just wondering, I can't imagine what life is like. I haven't seen it. I don't know what to expect from it. But as Jess was saying to the mentor piece, 5 days after the bombing, 5 Marines walked into my room, my hospital room, and 4 of them were amputees and 1 of them used a wheelchair, and they didn't have to say a word. Just the fact that they had strolled into my hospital room, smiles on their faces, muscles, back to work, in relationships with children, like life was continuing for them. And they gave me such a charge of hope, and for my family, really. These are people who are still friends to this day, and they erased a lot of fears from me, because I still didn't know exactly what my end game was, but I knew what was possible by seeing these guys, and that was incredibly powerful.
And I have all the fears. That's why we're married, because he apparently doesn't have any. My big fears are aging. I wasn't planning on aging like this, and so I am very fearful of what that has in store for us and what that looks like if we're fortunate enough to age. And for hopes, I think it's just that Patrick and I continue to find a way to live a really happy and full life that looks a lot different from what we planned on. There's still, we're sitting up here, we're excited to tell you we're back to work and we're doing this and we're doing that, but there's still a lot of things we struggle with. Like what this majorly interrupted any family planning we might have had. So like, what does that mean to us now? How does that look? So my hope is that we find a way to do that together and in a way that's just very happy and fulfilling.
Great, thank you. I think we have some time for questions. Lot of topics being covered here. So I think we have about 5 minutes for questions from anybody.
We are not shy.
I can give up my microphone, or give up one of you guys' microphones.
Thank you for sharing your experiences. It's really powerful. We are limb recon surgeons, and so we spend a lot of time engaged in limb salvage. But most of us have experience with amputation as well. because, you know, there's that balance between doing the two, and it's not so simple. I mean, as you gave us a little bit of an insight into that. Your dilemma of choosing sort of the elective amputation is something that comes up for us quite a bit, and it's difficult because I think what we've learned, a limb salvage that doesn't work sucks, but a limb salvage that does work has roughly the same functional outcome as an amputation. That's pretty much, I think most people would agree with that. I mean, you know, amputations have very high functionality. And so, you know, trying to make that decision is a tough decision. And listening to you in your, you know, that dilemma where you were really, you know, where, you know, you didn't have an infection anymore, that comes up. And, you know, you illustrated some of the decision making with that, but that, I bet that was a really tough one. And, you know, the idea of when you can become emotionally detached from your leg to make that decision. I know you've done it already, but maybe you could talk on that a little bit more.
Yeah, no, it is the most gut-wrenching decision I've ever made. It's very unnatural, and it's the most permanent one. I mean, even who you marry is really not permanent, right? I mean...
Wow, Patrick, once again, wow. This is tough.
But seriously, like, there's no going back from amputation, is my point. There really isn't. So it is very permanent. It was a journey. It was at times very lonely, and I don't know that you can skip over that, you know. You can't. I don't want to leave you here thinking that all your patients can have these easy, nice, clean journeys, and you're gonna know who to amputate and who to save, and it's gonna be great. I hope you leave with how to be a better companion along that journey than maybe you were before. And I think things like, you know, and I would say a saved limb is better. Like, I tell kids all the time when I go to schools, I can't feel the ground anymore. There are times when I would love a human foot to tell me where my other leg is in space, or that there's ice on the ground, or that cord is there. I mean, don't get me wrong. I drop the soap in the shower, and I miss having that one busted leg to brace myself with. So I just think finding, being there, being a safe space for them to say what they're really thinking and feeling. They might have a family or friends that thinks amputation is just so horrific that they can't say it out loud to them. Knowing that it's not failure if they amputate, and that their success is going to be defined by them, but because it is such a permanent decision, that they owe it to themselves to try these different things. But having a timeline can be helpful, you know, because I think you get these patients that just, they want to get back to life, and maybe they've met these other people or seen these other amputees, because we know a nice recovery from an amputation, they're up and out of the rehab when you're still doing this, like, you know, baby stuff in the physical therapy gym. But it was a very long journey. I mean, how about as my husband?
Well, I do think that the family component is an important one, that families become caretakers and are immersed in all the stress that comes with this decision making, and sometimes can provide more objective information of what someone's able to do or not do, and bringing them into the conversation if the patient's open to that, and including them in the decision making, or just the appointments as you are deliberating over all the permutations, because the patient very often gets overwhelmed by all of the possibilities, and having a team there can be really helpful.
And I guess when I talk about mentors too, absolutely connect them. I met one successful limb salvage patient who was same as me, a BK on one side, limb salvage on the other, and he was living his life he wanted to live. He was achieving all of his, you know, goals. So he was the only one I got to meet, but I did get to meet one. But so if you have those patients that are similar, enough just to like bounce ideas off of, or how did you know, or what did you do for this, is just can really get people through those really long, dark times where they're really losing hope. And at the same time, I think someone who is heading towards amputation, to start to see the prosthetics, it takes a while for your brain to like really be okay. And I did kind of have to detach for it. I started to hate that leg. And you've got to start.
Almost intentionally. 'Cause
Yeah.
It's like having a teenager who's unruly leave the
Yes,
house.
absolutely. I just saw it as this thing that was holding me back. And we spoke at this OT conference, and I did have this weird relief after my amputation where I talk about being symmetrical again. It was oddly nice to be symmetrical again. It's so weird, but it is a process. Yeah.
Thank you. Any other questions? Yeah, Joe.
Offline, I'd love to talk about the SecDef stuff that the bill y'all are proposing with Senator Warren. As far as one of the comments that you actually made was around the pain management portion and your inability to actually understand what was going on. This is a topic that a conversation I've had with many wounded warriors over the years. We want to be part of the shared decision making, want to bring in peer counselors, and so what is your advice from the perspective of going through this, how to work through the pain management portion so that you have your faculties about you to help make long-term decisions for you and your family?
It's a great question. I was not able to be a part of my treatment planning process initially because I was so overwhelmed by the pain or experiencing so many of the side effects of the pain medication once the pain had subsided, but the medication had really kicked in. For me, it was nerve catheters that were like a godsend. Once, they would get misplaced sometimes, they'd have to replace them, but it allowed the pain to subside and then for me to be mentally present to be a part of these conversations. I'm certainly no expert in pain management, but what it came down to for me was communication with my team. I call them the pain train because they would all come in as this big team. And I loved these people because I knew they were listening to me and I could really tell them what I was experiencing, and they never quit on me. They kept trying all these different iterations to see what would finally work. And thankfully the nerve catheters did. And I thought that was totally a result of our ability to collaborate with each other.
Yeah, I would say if it's appropriate for your patient to have a nerve catheter, it is such a game changer. I mean, I avoided narcotics for like the last 3 years of surgeries, and I did, so much better. It's mentally intact. I was participating in PT within a day or two of surgery, and then the constipation, double vision. We're all getting way more aware of the possible dependency issues. I do think it's possible to have these major orthopedic surgeries and not need any narcotics. And frankly, they don't work, at least in our experience, they didn't even manage the pain that well. So you're getting this whole host of crappy side effects without any good ones. Those peripheral nerve catheters were like, they were just great. And really not a major downside, at least from our perspective. You have to have people that are very proficient at putting them in, and they have to be clinically uncomplicated enough to have them. But that was like night and day for me. And I do think it's important to get to know your patient enough to know when a mentor is going to be helpful or not. I think sometimes if someone might be really against amputation, and to have an amputee come walking in their room might be like a lot, and they don't want to see it or talk about it yet. You're not going to be perfect all the time and be able to read that, but just do your best to try to figure out if it's a good time, if it's not, where they are. There was a long time because he loved those wounded warriors coming in his room. For me, I had put a blanket over all of it, and I didn't want to talk about it, and I was pretending it wasn't there. So for me, it was kind of alarming to have all these amputees come in because I didn't want to be them. I wasn't acknowledging that I was one. So I think you're going to have patients all over the board. And again, you can't do it perfectly, but you can do your best.
Yes.
Okay. Thanks for sharing your story. And I think that for the orthopedic surgeons in the room, when you've done an amputation, you often, you might see the wound at 6 weeks or 8 weeks and and see that the patient the wounds are clean and dry and everything's healed, and then it's handed off to the orthotist and the prosthetist. Do you still have a relationship with your orthopedic surgeon?
I do, and Jess does. Our relationships with these people perhaps were a little unorthodox. We've gone to parties with them to thank them, Jess weddings, and Jess has a big crush on her ortho surgeon from Walter Reed. So there's some blurred boundaries, but we have stayed in touch with these people. I think also because we realized that we needed ongoing care and perhaps reconstructive surgeries, or maybe surgeries in 5 years from now or 10 years from now. So it's been very important for us to maintain those relationships because they know our bodies so well now. So if we do need a surgery, we want to go back to them. There's something we're trying to maintain there.
Sure.
I guess I'd also say at Walter Reed anyway, the surgeons they don't operate and then they're done with you. They're coming into the gym, they're coming to the prosthetic clinic. They were very familiar with prosthetics. They knew all the different types, how they stay on, how they fit, what a good fit is. I mean, they were almost as knowledgeable as your prosthetist. So they were a real, I think in the civilian world, you're like, well, why am I gonna call that person? I'm done with the surgery part, I'm on to this part. They don't know about this part. That wasn't our experience there. So there was like, yes, we had personal attachments to them, but it was also, there's still a great source of, we were still needing them, in other words. So there was a motivation to stay in touch with them.
What we also found that when we were at our worst, depressed, in pain, immobile, we were asked to go to all corners of this city. Go to one corner for our orthopedic surgeon, another corner for our prosthetist, another corner for our physical therapist, another corner for our psychologist, and no one was really talking to each other. And when we went to Walter Reed, all of those people were in the same building, separated by one floor. And that radically changed our care because people collaborated with each other. You could literally get your entire treatment team in a room to troubleshoot a problem and then all implement the same treatment plan as you left that door. And as any of you know, that's huge.
And part of the reason I ask, though, is that I think that what will happen very quickly is that the world of amputation and for the orthopedic surgeon will become this revolution in reconstructing the amputee. And there'll be all sorts of new alternatives for you that will become available within the next several years. And it does become a very multidisciplinary effort, and we work very closely with the prosthetists, with the physios, with the pain management, with the surgeons all working together as well. I think that a very important thing for you to understand and realize, and for everybody here to know, is that those of you that deal with the post-traumatics and the amputees and limb reconstruction is about to enter a brand new phase for you as osseointegration becomes something that's widely available, that targeted muscle reinnervation, that AMIs, which are agonist-antagonist myoneural interfaces. There's lots of other things that will become available for you very quickly.
So you're an expert in osseointegration?
Yes.
And that's happening a lot at Walter Reed, and so we've seen that team approach. We've also seen that team approach for our friends who have upper extremity amputations who have now received arm transplants, and the multidisciplinary care that goes into maintaining, to not only do that surgery and assess for it, but also to make sure there's long-term success. And it's very much a team approach with all these new interventions. Not to mention stuff at like the MIT Media Lab with all kinds of new interfaces with prosthetics and how they can be integrated with nerve activity and muscle activation and all those sort of things, which for us is huge. I mean, our prosthetics today are already revolutionary compared to a generation ago, and it's exciting to see what's still on the forefront and how we might need some reconstructive surgeries to allow us to better interface with those new technologies.
Are you telling us though that you're going to be doing? Are you doing it on BKs yet?
Yes.
Really?
In Australia, it's yes.
And how well is it going?
Beautifully.
Beautifully.
I'll elaborate. Yeah. For the.
I have not met any BKs. I've only met AKs and really AKs that were not using traditional prosthetics.
Yeah. So for transfemoral, it is a no-brainer in that it restores a limb to them, and they are twice as functional and twice as happy. But for the below knee, because so many of them function so well already, and so there's a smaller percentage that will truly benefit, and it's a big leap to take to move into an area where you're going to do something for their convenience, for their own personal satisfaction and things. But there are many below knees or bilaterals that will definitely benefit.
I just feel like 3 metal poles in our bed at night could be kind of dangerous. I don't know. We'll have to talk.
So
offline conversation with Dr. Tetzworth.
So to balance that conversation a little bit, I think that some of those newer technologies, newer techniques, some of the stuff that's happening right here, as you said, in the Boston area, some of the stuff's happened in Australia, Sweden, that led a lot of this stuff. I think a lot of it has to be entered into with the same decision, the same complex decision making that you actually went through with, do I keep this leg or do I move on? And comparing those functions, doing activity logs and seeing really where you are, because especially below the knee, well-functioning transtibial amputees do pretty darn well, even short, as you know, even a very short transtibial amputee can do very well.
Right. Thank you.
Great. I think, okay, final question, then we have to wrap it up, unfortunately.
Thank you for coming and sharing your story. It's amazing and lovely and inspiring. I was wondering if you could talk just a little bit about the time that you were doing through limb salvage. I think you glossed over how many surgeries and issues you had. Could you talk a little bit about how that was handled in terms of the communication? When something came up, did you think it was a failure on the surgeon's part? Did you think it was a failure on your part? Did you just think this is doomed? I'd be really curious to hear how your interactions, because limb salvage, as you know, is fraught with difficulties, obstacles, and complications along the way. And how is that best and worst handled when you were going through it?
I had the experience of being with a lot of different care teams, for better or for worse. And initially, I did feel like maybe it was that my mental health was so poor and I was on so many medications. Maybe the communication wasn't as bad as I remember it being. But I felt like they, at least with the initial limb salvage stuff, it looked good. The flap was viable. So like, why are you calling? And I'm sitting here going, I can't wear a shoe. I can't walk. I can't do, it was like mind blowing to me. I just felt like I was on a totally different page than they were. With the setbacks, with the limb salvage surgeries, with different teams, I felt like they were in it with me and respected my feedback. And I do think for me, like I've said a couple of times, the timeline was so important, that like, this is a reasonable amount of time to wait. We can reevaluate it here. We're gonna try X, Y, Z. We were all on the same page with it. And that made a big difference. I remember being disappointed, but there was no one to be mad at but the universe, frankly, that this was happening and that I was having such a hard time. And I have a tendency to just put it on myself. Like I thought that I wasn't trying hard enough. Like I remember wishing that I could go to the doctor and they could measure my pain and they'd go, holy shit, it's off the charts, you need an amputation. I mean, that was my dream, because otherwise it's just me telling you I can't grocery shop and me telling you I can't live my life like this, but you can't crawl inside my body. But as much as they could, I felt like they were in it with me. And then even as a double, when I was having all these problems and setbacks, again, I just felt like it was something about me. They were very open with me. They would say things like, we have absolutely seen all these things here at Walter Reed. We don't typically see them all in one patient. And that was hard to hear, but it was reassuring to know where I was on that spectrum, to know that I wasn't bad or wrong or not trying, and that sometimes you're just having shitty luck because you're having shitty luck. And I think it's no one's fault. It wasn't my PT not doing something. It wasn't them not scrubbing in right in the OR. Like, these things happen and this is why they happen. I think is so important to communicate that. I don't know, it'd be so interesting to have you talk to my main surgeon, because I do feel like I messed with his self-confidence a lot. Like, I think he really started to why can't I get this girl better? I I looked so straightforward compared to a lot of the other cases at Walter Reed, but that wasn't my recovery. And as far for the number of surgeries, I literally stopped counting. It was too upsetting to count. I don't feel like a surgery count ever, it doesn't explain my experience. And I think sometimes we get caught on, oh, you've had 17, or I've had 23, so I say things like, I had surgery nonstop for 5 years, because that was my experience, and that better captures it than a number. That was important for me too. Anything else I'm missing? But thank you for your question, I appreciate it.
And thank you very, very much. Thank you.
Truly, thank you all for your time and dedication to your patients and your profession, and for bettering yourself on your time off. That's really impressive, so thank you all.